Salpingectomy is the surgical removal of one, unilateral, or both, bilateral, fallopian tubes. Fallopian tubes allow eggs to travel from the ovaries to the uterus. Salpingostomy is a procedure in which the contents of the fallopian tubes are removed by making an opening. Oophorectomy or ovariectomy is a surgical removal of one or both ovaries. Salpingectomy, complete or partial, unilateral or bilateral. Through a small incision in the lower abdomen just above the pubic hairline, the physician removes part or all of the fallopian tube on one or both sides. The incision is closed by suturing. Oophorectomy, partial or total, unilateral or bilateral. Through a small abdominal incision just above the top of the pubic hairline, the physician removes part or all of one or both of the ovaries. Salpingo-oophorectomy, complete or partial, unilateral or bilateral. Through a small incision in the abdomen just above the pubic hairline, the physician removes part or all of the ovary and part or all of its fallopian tube on one or both sides. The incision is closed by suturing. Oophorectomy, partial or total, unilateral or bilateral, for ovarian, tubal or primary peritoneal malignancy, with para-aortic and pelvic lymph node biopsies, peritoneal washings, peritoneal biopsies, diaphragmatic assessments, with or without salpingectomy, with or without omentectomy. Through an abdominal incision extending from the top of the pubic hairline to the rib cage, the physician removes part or all of one or both ovaries depending on the extent of the malignancy. The physician takes a sampling of the lymph nodes surrounding the lower aorta within the pelvis and flushes the peritoneum, which is the lining of the abdominal cavity, with saline. The saline solution is suctioned from the peritoneum for separately reportable examination. Multiple tissue samples are excised. The physician also examines and takes tissue samples of the diaphragm. The physician may elect to remove one or both fallopian tubes and the omentum. The abdominal incision is closed with layered sutures. Bilateral salpingo-oophorectomy with omentectomy, total abdominal hysterectomy and radical dissection for debulking. Through a full abdominal incision extending from just above the pubic hairline to the rib cage, the physician treats an ovarian malignancy. Additionally, the physician may excise pelvic lymph nodes and partially remove para-aortic lymph nodes. In either procedure, the physician makes a full abdominal incision and carries dissection down to the abdominal cavity. The physician excises the fallopian tubes, both ovaries, the uterus, and the omentum, which is a membrane containing lymph, blood vessels, and fat in a protective layer that extends from the stomach to the transverse colon. The physician removes or reduces metastatic ovarian cancer implants from the abdominal cavity. The abdominal incision is closed with layered sutures. Bilateral salpingo-oophorectomy with omentectomy, total abdominal hysterectomy and radical dissection for debulking, with pelvic lymphadenectomy and limited para-aortic lymphadenectomy. The physician additionally removes pelvic lymph nodes and a portion of the lymph nodes that surrounds the lower aorta within the pelvis. Bilateral salpingo-oophorectomy with total omentectomy, total abdominal hysterectomy for malignancy. The physician performs a bilateral salpingo-oophorectomy with total omentectomy and total abdominal hysterectomy to treat a malignancy. A full abdominal incision is made extending from just above the pubic hairline to the rib cage. Dissection is carried down to the abdominal cavity. The physician excises the fallopian tubes, ovaries, the uterus, and the omentum. The supporting pedicles containing the tubes, ligaments, and arteries are clamped and cut free. The uterus and cervix are removed along with a narrow rim or cuff of the vaginal lining. The vaginal defect is often left open for drainage. Attention is directed to the omentum, a membrane of lymph, blood vessels, and fat that forms a protective layer that extends from the stomach to the transverse colon. The omentum is mobilized from the stomach and colon, divided from its blood supply, and removed. The physician inspects the abdominal cavity and removes any metastatic lesions. The abdominal incision is closed with layered sutures. Salpingostomy, salpingonostomy. Through a small incision just above the pubic hairline, the physician creates a new opening in the fallopian tube where the fimbrial end has been closed by inflammation, infection, or injury. The procedure is generally performed microsurgically in order to do an accurate repair. The following definitions apply to the vulvectomy codes, 56620 to 56640. Simple, the removal of skin and superficial subcutaneous tissue. Radical, the removal of skin and deep subcutaneous tissue. Partial, removal of less than 80% of the vulvar area. Complete, the removal of greater than 80% of the vulvar area. Vulvectomy simple, partial. A complete vulvectomy includes removal of all of the labia majora, labia minora, and clitoris. Vulvectomy simple, complete. 2 wide elliptical incisions encompassing the vulvar area are made. 1 elliptical incision extends from well above the clitoris around both labia majora to a point just in front of the anus. The second elliptical incision starts at a point between the clitoris and the opening of the urethra and is carried around both sides of the opening of the vagina. The underlying subcutaneous fatty tissue is removed along with the large portion of excised skin. Vessels are clamped and tied off with sutures or are electrocoagulated to control bleeding. The considerable defect is usually closed in layers using separately reportable plastic techniques. Vaginal gauze packing may be placed in the vagina. Vulvectomy radical method. The physician removes part of the vulva to treat malignancy. Through incisions in the lower abdomen, thighs, and vulvar area, the physician removes skin, subcutaneous fatty tissue, and deeper tissue. Also included in the en-bloc removal of tissue are portions of the saphenous veins and ligaments and the target lesion. The resulting large and disfiguring defect is usually closed in layers using plastic surgical techniques, which may include pedicle flaps or free skin grafts. Subcutaneous rubber drains may be left in the surgical site, and vaginal gauze packing may be placed in the vagina. Vulvectomy, radical, partial. A partial radical vulvectomy includes partial or complete removal of a large, deep segment of skin from the following structures: abdomen and groin, labia majora, labia minora, clitoris, mons veneris, and terminal portions of the urethra, vagina, and other vulvar organs. Vulvectomy, radical, partial, with unilateral inguinofemoral lymphadenectomy. With bilateral inguinofemoral lymphadenectomy, the physician removes part of the vulva to treat malignancy. The physician also removes superficial and deep inguinal lymph nodes and adjacent femoral lymph nodes. Vulvectomy, radical, complete. A complete radical vulvectomy includes the removal of a large, deep segment of skin and tissue from the following structures: abdomen and groin, labia majora, labia minora, clitoris, mons veneris, and terminal portions of the urethra, vagina, and other vulvar organs. Deep tissue from more than 80% of the vulva is excised. Vulvectomy, radical, complete, with unilateral inguinofemoral lymphadenectomy. With bilateral inguinofemoral lymphadenectomy, the physician also removes the inguinal and femoral lymph nodes. Vulvectomy, radical, complete, with inguinofemoral, iliac, and pelvic lymphadenectomy. The physician also removes the inguinal and femoral lymph nodes on both sides as well as the iliac and pelvic lymph nodes in the pelvic cavity, which is entered through an abdominal incision.